Hello everybody, my name is Wendy Jones. I'm a pharmacist and my speciality is the safety of drugs in breast milk. I've become quite passionate over the fact that we need more healthcare professionals to understand how drugs get into breast milk and how we can use that information to decide whether drugs are compatible with ongoing breastfeeding and the safety of the baby. So pharmacokinetics and transport of drugs into milk really is a very posh technical term for how drugs get into breast milk. And I think it really is essential to just have a bit of a reminder, a refresher, as part of ongoing CPD, just to understand what the barriers of drug getting into breast milk is and how we can ascertain whether a drug is compatible. So how do we evaluate the risk of a drug? How do we help the mum to manage her breastfeeding? How do we actually support the mother to continue her breastfeeding? And how do we evaluate the risk of the drug passing through to the baby and the risk of not breastfeeding? Most drugs pass into breast milk by simply diffusing across the cell membrane. Simply diffusing makes it sound very easy, but there are actually very many barriers for a drug to pass into milk in this way. And 99% of drugs pass this way. It's probably about the same number of drugs that actually are compatible with breastfeeding if we look at the way they actually transfer. The time of the greatest transfer of drugs into milk is in the first few days after birth, when the alveolar cells in the epithelium have massive gaps between them to allow immunoglobulins to pass through in order to protect the baby. These are giant molecules and couldn't get through in any other way. But in having these gaps wide open, there is also free flow of any drug that we give to a mother. But this is probably the time at which we give most of the drugs that we are going to prescribe to mothers. We may be giving them analgesics, we may be giving them anesthetics, antibiotics, laxatives, a huge number of drugs. But this is normally undertaken in a maternity unit where prescribing in lactation is something that happens every day. The other thing in the first few days is that the total volume of colostrum that is produced is very small, so the absolute amount of drug that passes through is very small. But after the first few days after birth, these intercellular gaps close up, and that's when the drugs have to cross the cellular membranes to get into breast milk, and this is much more difficult for them. When we're looking at the safety of a drug, the first thing we need to consider is what is the half-life of the drug. Now, the half-life of a drug is the time taken for half of it to be metabolized by the person who is taking it, so that 50% of the original drug is left in the body. So after 2 half-lives, 25% of the drug is left in the body, 3 half-lives, 12.5%, and so on until at 5 half-lives, the drug is assumed to have left the mother's body and therefore also her milk. So that's why we prefer to have drugs with short half-lives, less than 24 hours for breastfeeding. And common examples of these are paracetamol and amoxicillin. If we have a drug with a longer half-life, it may start to accumulate in the baby's system. So let's say the half-life is 36 hours. After 24 hours, we have a certain percentage of the original drug left. I've used 80% here as an example because I'm not very good at maths. So we've got this portion of the first day's drug given, and then we give another 100% of the drug. So let's say we have 180%. After 2 half-lives, there's a proportion of the first dose, a proportion of the second dose, and then we give 100% of the third dose. And so on and so on. And you can see how this is leads to accumulation of the drug in breast milk. And it can reach levels where there will be adverse effects in the baby. One example of that is fluconazole, which may be given for nipple thrush. In a baby over 6 weeks of age, the half-life is the same as it is in the mother, 30 hours. But in a baby less than 6 weeks, there is an extended half-life of 88 hours due to impaired or immature hepatic and renal function. So we may be giving this drug every 24 hours, but it's taking 88 hours for each day's drug to be cleared. And that's why we can sometimes see adverse events in the baby. With respect to fluconazole, I've seen babies about to be admitted to hospital for an operation for pyloric stenosis because they are vomiting so severely. Chronic stomach pains, loss of weight are not at all uncommon. And that's why when I talk about treating breast thrush, I want to be very sure that this is what we're treating, not poor attachment, before we expose a tiny baby to this drug. Drugs with poor oral bioavailability are ideal to be given to a breastfeeding mother because the molecules are so large they can't pass through cell membranes. And these are drugs which are only given by an injection or infusion, and no oral product is available. So no matter how much gets into the milk supply, the baby can't absorb it. So examples of this are things like gentamicin, ticapain, and meropenem, which may be infusing into the mother, and it may possibly, but in very small amounts, pass into milk, but the baby can't absorb it. The same is true for most of the biological agents that we use for things like rheumatoid arthritis and inflammatory bowel disease. The therapeutic range varies between drugs. Some drugs we know have very narrow ranges and need to be monitored, and examples that we're all aware of are things like digoxin, lithium, and warfarin. Others have very wide ranges so that the doses aren't critical. For instance, we may be giving a mother 2 by 500 milligrams 4 times a day, but even quite a small child may be given 250 milligrams 4 times a day. It doesn't matter, therefore, if the mum is taking paracetamol, the baby develops the same temperature and needs also to take paracetamol. We're not going to be exceeding the therapeutic range, so they can both have their full normal doses. Any drug which is licensed to be given to children will be safe when given to a breastfeeding mother, as it will reach subtherapeutic levels. Examples of that are things like mebendazole given for threadworms. We actually give the mother and small children the same dose, and also the non-drowsy antihistamines like loratadine and cetirizine. But as I said in the last slide, if we exceed therapeutic levels, then we can have side effects and toxicity. Drugs which are highly protein bound to albumin proteins in the mum's plasma is also find it very difficult to transfer into breast milk. Ideally, we want a drug which is more than 90% plasma protein bound, but data on this is only available in specialised text. It isn't in the standard BNF. So I will come to these specialised texts in a moment. But remember, we need drugs which are highly protein bound in an ideal world. We also want drugs which pass less into breast milk and stay within the mum's plasma levels. So the ratio between these two is less than 1. If a milk plasma ratio is above 1, it suggests that the drug concentrates in breast milk. And this may be through iron trapping, or it may be an active transfer. So, for example, we want to avoid iodine because the milk plasma ratio can be up to 26. So even using iodine dressings to cover a wound may result in toxicity to the baby. Alcohol, it's often known that the milk plasma ratio is 1. So the mum's level and the level in breast milk actually stabilize. But as the level in the mother's blood falls back, so the drug is pulled back out of breast milk. You may remember the science experiments at GCSE where you have a membrane and you put a high dose dye in one side and you watch it pass into equilibrium as it goes through the membrane. It's a two-way process. As the mum's plasma level drops, as the mum metabolizes, it comes back out of the drug. But I want to go back to cannabis because cannabis has a milk plasma ratio of 1, and its pharmacokinetics mean that it will actually cross the blood-brain barrier and sit in the fat cells in the baby's brain. And we still have no idea what this will be as the baby grows older. So it's a drug which is of concern to me. Many mums are told that the maximum level of drug in her breast milk will be achieved after 1 or 2 hours after she takes it, and to try and avoid feeding at that time. And they're very desperately to time their feeds with drug levels at their lowest. This works fine if we are talking about an acute drug, but just as it takes 5 half-lives for a drug to leave the maternal system, it takes 5 half-lives for a drug to reach a steady state. And at that point, the level has a small peak and trough, but it's staying, as you can see in the diagram, at a steady state. So if we're using something like sertraline, which is a half-life just marginally over 24 hours, by the time the mum has taken it for 5 days, there are no peaks and troughs. So telling a mum who may already be very anxious to try to time her feeds will add to her anxiety and achieve absolutely nothing. If a mum has to temporarily suspend her giving breast milk to her baby, she has to pump her milk to maintain her supply and also to minimize the risk of mastitis. But there are several things that we need to consider before suggesting that it is just to be discarded. Just the word dumping makes it sound that it's valueless, and as professionals, we probably don't understand how disheartening it is to throw away milk, which we always value as the best nutrition for the baby. We know that exclusive breastfeeding for 6 months and ongoing breastfeeding alongside appropriate solids for 2 years and beyond is the best way to maintain the health of the baby, with benefits for both mum and baby. I often encourage practitioners to talk about pumping and saving the milk if they need to go away and check specialist sources. I'm very aware that whilst this is something that I do day in and day out, professionals may have to go away and check specialist sources and see if a drug is compatible with breastfeeding. And we don't want to risk her continuing to breastfeed if we perceive a risk. But don't just say throw your milk away as a throwaway unnecessary comment, because particularly if a mum is depressed, breastfeeding may be the only thing that she feels positive about, and suggesting that she stops for a period of time or altogether may be taking away the only positive in her hand. in her life. And also, you're taking away the value of the oxytocin that she produces when she is feeding, which actually stabilizes her hormones, relaxes her, and makes her happy. We often underestimate the power of oxytocin, the hormone of love. So, this is an example of lack of understanding about the safety of a drug taken by a breastfeeding mother. These are the mum's own words. I rocked up at 8 a.m. with my 5-month-old son and my husband to babysit because I was having an MRI. That sounds quite simple, but actually, to be somewhere fully dressed with a child ready to be left with a partner by 8 a.m. in the morning might not be at all easy. 20 minutes later, she was back in the car because she was told she couldn't have the procedure if she was breastfeeding. Almost certainly, she would have been told that she had to stop breastfeeding for 24 hours because that is the standard recommendation from most units. She'd messaging me that actually the baby is now almost 1 year old. She just had the MRI. She's still breastfeeding, but nobody thought to ask her. Now, the oral bioavailability of gadolinium, the contrast in the MRI, is 0.8%, exceptionally low. And the half-life is 1.7 hours. So even if we were to tell her to wait for 5 half-lives till it's all gone, we still only got to 8.5 hours. And yet the standard information is don't breastfeed for 24 hours. We're not using the pharmacokinetics to support the mother. But in addition, what was the cost to the NHS of the cancellation of this procedure? What about the mother's health? She waited 7 months to have this procedure. So much could have gone wrong in that time. I have the privilege of working with a group of anaesthetists and helping to publish anaesthesia and sedation guidelines. For many years, I had been exceedingly frustrated by mums having surgery told that they can't breastfeed for 24 hours. Yet we undertake emergency cesarean sections under general anaesthetic and put the baby to breast in theatre when the drugs are passing straight through those intercellular gaps. But if the baby was 9 months old and the mum has been admitted for gallstones, she's still told she can't breastfeed for 24 hours. There was no evidence, and it seemed that it had just become custom and practice. But let's say the mum has been admitted in an emergency. She needs to remove the milk from her breasts if we stop her feeding for 24 hours. Otherwise, she's risking mastitis, and then we need to give antibiotics, and we may be making her ill. And there's always an assumption that all babies will drink from a bottle because every toy that you buy for a child tends to come with a bottle. So a dolly comes with a bottle, a teddy comes with a bottle, My Little Pony comes with a bottle. But not all babies will suck from a bottle. It's a completely different technique. When you feed from a bottle, you use your cheeks. When you feed from the breast, you use the whole of your jaw, which is why you have better jaw development in breastfed babies. And we weren't thinking about the risks and the benefits of changing what the mum was doing. Similarly, I was involved in this small study in Ireland looking at what breastfeeding mothers were told, not just about MRIs, but CT scans. And 70% of professionals were recommending mothers pump and dump. And yet the contrasts within CT scans are just as poorly bioavailable as the gadolinium in the MRI scan. And this is something that makes me very sad. We're protecting ourselves and reputations without thinking about how important breast milk is for the health of the child in the future. We see formula milk as being exactly the same. Formula is fine. It supports nutrition of many very babies, but it doesn't have all the specialist properties that breast milk has. So this is the list of resources that I would recommend that you use. Of course, top of my list has to be my books, which will be on the next slide. But LactMed is freely available and you can download an app onto your phone, as I do, so that wherever you are, you can look up the safety of most drugs and look at all the research behind them. UK DALIS, which is part of the UK Medicines Information Service, also has lots of articles and you can phone them as a professional to discuss the safety of a drug in breast milk. They do for the NHS this exactly the same as I do. I just don't work for the NHS, I work for a charity. Much of their work is during working hours on a telephone or very detailed fact sheets. Ours is largely via social media and usually to mums, and it's 7 days a week, 365 days a year. The textbook, which is the one beyond excellence, is Hale's Medications and Mother's Milk. It's quite a thick tome, updated annually, and it includes just about every drug that you could possibly wish to look up. You can also access it online by a paid subscription. What I've tried to do is take away the work for you and provide simplified fact sheets for which mothers and professionals can both access on the safety of drugs in breast milk. So the BFN fact sheets include things like analgesics, antibiotics, asthma treatments. Mine are often taken from my books and may look at in a different way at things like terminations or stillbirths. If in your local pharmacy you have access to Martindale, the information is usually in there. But I always find I need an extra large pair of glasses to be able to help me to read the entries. And I'm also very happy that anybody should email me for information to help them in decision making. We all live by the principle, first do no harm, but we need to remember that breast milk doesn't turn off like a tap and that there are risks of suddenly interrupting breastfeeding. It can be mastitis, it can be a baby refusing to feed, it can be a baby intolerant to formula, and we also may impair the mum's future milk supply because the supply has dropped in the time that she has stopped breastfeeding, and we need to help her to re-stimulate it. If a mum is told that she should interrupt breastfeeding, she also should be given a clear plan as to how to start again and when to start again. I remember some time ago a mum being told just before Easter that she had to stop after a dental procedure. And she contacted me 7 days later and said, "How much longer do I have to wait?" Nobody had thought to tell her when she could go back to breastfeeding. If she has to pump, does she have a pump? Does she know how to use it? Is she pumping frequently to avoid the risk of engorgement or mastitis? Is she using too high a pressure and causing damage? Talking to your local infant feeding coordinator, lactation consultant, somebody who is an expert in understanding breastfeeding would be valuable. We can't all be experts in every field. We need to know who to go to help us. So what we want to choose are drugs which are licensed for children, if possible, and drugs which we have data on. That might be maybe not the newest drug that we have available. It might be slightly more old-fashioned. So we might want to use low molecular weight heparinoids rather than the newer versions of drugs which are anticoagulants, on which we don't know whether they are safe in breastfeeding. We want to look at all the pharmacokinetic data in our specialist sources, so the bioavailability, the plasma protein binding, milk plasma ratio, and most importantly, 3 words that if you remember nothing else today from this presentation, I hope you'll remember that the relative infant dose should be below 10%. That is only in the very specialist sources. So a couple of examples to show you what I mean. Propranolol can be used for anxiety, for preventing migraines, panic attacks, used extensively. It's 90% plasma protein bound, but it also undergoes significant first pass metabolism, which is why the relative infant dose is so low, significantly below 10% at 0.3 to 0.5%. So it is a safe drug to be used during breastfeeding. Sertraline is probably the most widely used drug for anxiety and depression. We have a lot of experience, many thousands of mums every year taking it and continuing to breastfeed. Plasma protein binding is high, and although the oral bioavailability is complete, the relative infant dose is at most 2.2%. You can have wide variations depending on whether the research is done when the drug is at a steady state. So that's why you should always quote the variations. Codeine is currently not recommended for breastfeeding mothers following the death of a baby in Canada whose mum had a metabolism that concentrated the metabolite morphine in her milk. The mum in the case actually kept reporting to her baby's pediatrician that the baby was very drowsy, but she was dismissed regularly and told to just go and seek lactation support and that it would all be all right. She herself wasn't tolerating it very well. If you have a mum who says, I don't like taking opioid drugs, they make me feel sick, dizzy, very constipated, that probably is a sign that she has this metabolism that would make codeine a drug which you would want to prescribe as the very last resort. If it's 8 o'clock on a Saturday evening and it's all the drug that she has, and she has a long night to get through without pain relief, she can't take it and watch her baby for drowsiness. The mum whose baby died, it died over a couple of weeks. It wasn't over one night. And in the past, we gave all postnatal mums codeine for all of the pain relief immediately after delivery. Dihydrocodeine is much safer because it isn't metabolized in the same way and it comes from the parent drug. No mum should have to choose between breastfeeding and having adequate pain relief. We should always be able to choose something to support her. When we're looking at antihypertensives, we may want to choose enalapril as an ACE inhibitor rather than ramipril, over which we have no pharmacokinetic data. It probably is just as safe. We can assume a class effect, but we can't prove it. We can treat neuropathic pain with the use of amitriptyline, gabapentin, and pregabalin. We have much less information on pregabalin from studies. There's one study of 10 mothers, but no babies in the study were breastfed. But the relative infant dose is 7.18, still below the 10%. Midazolam is a drug which we use frequently for a variety of sedative procedures. When I first looked at it, the information was to avoid breastfeeding with a young baby for 4 hours after the procedure. But when I traced the research back, it was looking at nitrazepam and midazolam as hypnotics in the first few days after delivery. But even with that transfer straight through into breast milk, after 4 hours, the level was undetectable. But if we're using a single dose as a sedative for, let's say, a colonoscopy, the amount in breast milk is very small and the mother can continue to feed as normal as soon as she is awake and alert. She may need to be careful the night after the procedure because she may be more tired, and if she is co-sleeping, her natural inhibitions will have been removed. We need to remember that lack of data, it doesn't imply lack of risk. It means we just don't have the data. we can't make the assumption. Sometimes we can find information, excuse me, sometimes we can't. So we can use pharmacokinetics to assess the safety of a drug. We can access specialist reference sources, and we can support mums with expressing if it's necessary and develop a care plan for them to continue breastfeeding. And most importantly, have some multidisciplinary team support to enable the mum to carry on feeding as she wishes. These are the books that I have written. All are available on Amazon, and most have Kindle versions as well. And I would encourage you to go and buy them. The Guide to Breastfeeding Support for the Medical Profession, I co-edited with Professor Amy Brown, and it has a wealth of information from the experts in the UK on a variety of different topics, from milk donation, the specificity of breast milk, tongue tie, depression, as well as the drug issues. Let's change the conversation. Let's give mums and their partners evidence-based information, and let's involve them in shared decision making and build their trust. Breastfeeding is probably one of the greatest areas of health promotion that we can be involved in. And all it takes is an understanding of how breastfeeding works, understanding of how drugs pass into breast milk, and a willingness to support mums. And we need to cascade this information. Let's train all the medics in the world to understand about the safety of drugs in breast milk. Not enough of us have information in our undergraduate training procedures. I'm hoping this will help you with your CPD this year. We need to use these evidence-based sources, and we need to be sensitive to the needs of mothers around infant feeding. It's as important not to ignore a mum who says that she has breastfeeding problems without sending her to a breastfeeding expert, or to discourage her from breastfeeding if that's the way she wants to feed. If you have any questions, please feel free to email me and I will do my best to help. Thank you for listening today, and I hope this has been useful.